Okay, people are still joining, but we'll go ahead and get started. So welcome everyone. Welcome to today's MIDAS webinar. I'm Stephanie Shadbolt, the Outreach Coordinator for MIDAS, and I'm hosting the webinar today. If you're new to MIDAS, MIDAS is a global network of researchers, students, and others who are dedicated to the modeling of infectious disease dynamics. MIDAS membership is open to anyone who is working in or has an interest in this area, and you can find the membership request form on our website at midasnetwork.us. And in today's webinar, we are again featuring presenters from our MIDAS COVID-19 Urgent Grant Program. We are grateful to NIGMS for their funding support, as well as all the applicants and especially the reviewers for their time and effort. You can read more about the grant program and the awards made on the MIDAS website. And we have one more open funding round for the supplemental part of the program. Just so that you know, the webinar is being recorded and the video will be available later on the MIDAS website on our events page. We are also live streaming to YouTube, so welcome to any of our viewers there. We have 3 speakers today. Each speaker will present for about 15 minutes with some time for questions. And then if we have time at the very end, we'll also open it up for some more questions and discussion. You can use the Q&A function or the chat window if you'd like to ask questions. So now I'm very happy to introduce today's speakers. Dr. Asma Azizi is a postdoctoral researcher at the University of California, Irvine. Her research focuses on developing, extending, and analyzing various models to understand and predict the spread of infections and to guide public health workers in improving strategies for mitigating the impact of disease. Dr. Pilar Fernandez is an assistant professor at Washington State University. She is a disease ecologist focused on the epidemiology of zoonotic diseases and in particular vector-borne diseases. And Dr. Thomas McAndrew is an assistant professor at Lehigh University. He is a computational scientist working at the intersection of biostatistics and data science, studying ensemble models, expert prediction, and crowdsourcing for forecasting infectious diseases. So very happy to have all our speakers join us today, and we'll start with Asma and then Pilar and then Tom. So I will stop sharing my screen and go ahead and invite Asma to start her presentation.
Okay, thank you so much, Stephanie. Let me share my screen first. Okay, so everybody sees my screen now? Okay, hello everybody. Thanks for coming to my talk. And today I want to talk about some preliminary result of my proposal, which was submitted recently. And it is about understanding some behavior of the coronavirus data. The title is Prolonged Infection Plateaus in COVID-19 Pandemic. So looking at the data of the coronavirus in different states of the country, we have seen different trends through different states. So we have categorized these differences, these different patterns into 5 different patterns called group 0 to group 4. Every group is including some states. And in group 0, we have seen some relatively sharp, increasing and decline of the infection during some time. And in group 1, 2, 3, which are almost close to each other, but they all have the behavior of the plateauing. It seems that, for some time it increased and they then decrease and stay constant for a long time, or just increase and stays constant for a long time. And finally, group 4, which is increasing sharply with no raise. So the question in our mind was about the behavior of group 1 to group 3. So where that plateau behavior come from? So we wanted to understand that. So looking at literature, we found some reasons about this plateauing behavior. There have been several studies which were using compartmental model or dynamical system model to understand this plateau behavior. And they provide different reasons, such as unusual initial condition, or because of the behavioral change in the middle of the epidemic. However, if we wanted to use compartmental ODE model, we could not use that for some states, because the growth of infection in that states was showing that we don't see exponential growth. Instead, they are best described by power law growth. So we could not use ODE model. So because of these two reasons, our goal was to use network model to understand, first of all, this power law growth of infection, and second of all, understanding the plateauing behavior in some states. Okay, so we start with our model, which is a simple SIR model, stochastic SIR model on the network. We have susceptible, infected, and removed people, which removed people includes dead people and also recovered people. We have probability of transmission per contact. We have recovery rate and death rate. We also use balanced initial condition to get rid of initial stochasticity of our simulations. And for parameterization, we use parameters that best describe the spread of coronavirus. So with that all, I use for recovery and death rate, I use literature, but for other parameters like probability of transmission, I use method of simulated moment to calibrate this value to effective reproduction number, which is reported in some literature. So after introducing our model, we want to superimpose the model on different network structure. We use several networks, toy networks from the simplest case, homogeneous Erdős-Rényi random network, which is not a good example of real-world network, but its result is closer to ODE model. We also use a scale-free network. One important feature of this network is existence of the hub. A few people who have too many contacts, and most of people have few contacts, so it has a fat tail distribution as well. We also use a special network in which the connection between people is defined based on the physical distance. And we believe that this example would be a good one for coronavirus, because at this time people limit their traveling and they stay at their home or at their city for a long time. So their connection is limited to the people who are living close to them. Okay. We also use, at the end, we are going to use that in real world network, which in the future slide I explain that. Okay, so after introducing the model and introducing the networks that we are going to implement the model on, the first inspection was about implementing behavioral change in the middle of the epidemic. So the behavioral change in our model is just by, mandated social distancing, which is ruled by government, and people have to follow that for a limited time. They start social distancing at some time T1, and they finish that at time T2. So here is the heat map of final size for Erdős-Rényi random network, which is closer to ODE model. And we see that, for example, if the x-axis is a starting time of the social distancing and y-axis is the end time of the social distancing. And darker the value means that less final size. So as you see, by increasing the duration of social distancing, final size decrease, but we don't have a monotonic behavior with respect to a starting time of the social distancing, which the reason is because of the model, which is SIR model. If people start social distancing very soon for a limited time, they waste their social distancing, they waste their protection at the time that they don't have too many infected around them. And if they start that very late, so for obvious reason, the final size increase. So there is an optimal point for a starting of social distancing. However, this result is just for Erdős-Rényi random network, but implementing on different networks, we see different structures. So we have to implement our model and social distancing on different networks. So here on the left panel, I implement the model on a special network and a scale-free network and their hybrid, and look at the cumulative infected versus time. And as you see in this graph, we see that, for a special network, for a scale-free network, we somehow have, exponential growth. But for a special model, when we use a special network, we see some power law growth in the epidemic. And for the hybrid one, which is combination of a spatial and Barbosi, it is just between them, some average to them, but more skewed to the power law behavior. On the other hand, if we use mandated social distancing with different level, we have different impact on different network. And we see here on the right panel, I have the fraction of age removed randomly, and the y-axis of the right panel would be the mean epidemic size for different network structure. As you see, for a special network, we have more impact on social distancing, which is because of the local spread of the infection. So when we cut more edges, more infected people become isolated, and it has more impact on the mean epidemic size. Okay, so however, we were guessing that, back to our question, we wanted to understand the plateau behavior. We were guessing that this plateau behavior comes from, first of all, network structure, second of all, because of the behavioral change in the middle of the epidemic. So to test that, we implement this social distancing on different networks and compare that with no social distancing at all. So here for each frame, I have, for different network structure, the first row of each frame refer to no social distancing, and the second row of each frame refer to some amount of social distancing. As you see, for most of networks, when we do social distancing, we see somehow some plateauing behavior. Epidemic increase and stay for some time, and then it start decreasing. And we see that more pronounced plateau in a special network more than the other networks. So we are going to zoom on a special network to see what's happening. So I use, just from now on, I use a special network, and I implemented social distancing with different level to see how plateau is coming to the simulation or not. Okay, so here I have a social network of degree 10, and I start social distancing at around when infection get 1%, and I use different level of social distancing which last forever. Okay, the left panel is the prevalence versus the time for different level of social distancing for a special network again. So when we have an intense social distancing, again, okay, sorry, need to mention that we start social distancing when the prevalence for all of them start at reached at 1%. So when the level of social distancing is very high, we don't see that plateau. It is a rise and then decline very fast because of the high level of social distancing. But by decreasing social distancing between, for example, 60 and 40%, we see that, plateau is becoming and appears. So especially if you look at 50%, which is blue dashed, we see more pronounced social plateau behavior on the prevalence. But when we decrease social distancing to a smaller value, it is still, even after starting to social distancing, it increased, but it reached the peak, and it stayed for the peak for some amount of the time. So it seems that for a low to medium value of social distancing for a special network, we have a plateau with different strength. So we look at the plateau duration, versus the cut percentage for this special network, two type of special network of degree 10 and degree 20 to check our, our guess, and we observe that. So there is a non-monotonic behavior on the plateau duration. And when we have the cut percentage is very low, we have a small, plateau duration, but it increased by increasing cut percentage to some maximum value. And then when we start social distancing with very high level, it start decreasing because of, isolating infected people and controlling the infection. That's why we don't have, for high level, we don't have, plateau anymore. Okay, but this result all were based on two assumptions. First of all, it was we start social distancing at 1% infected. Second of all, it was, for a special network. So what if we use other networks to see how our result is robust to the, network structure and the time of, starting, social distancing? We assume at the beginning time, our network is a hybrid network, which is connection of the special network and some which has close edges and some far edges, which come from, for example, a scale-free network. So when we reach at, for example, some threshold of prevalence of, say, 1%, we cut all far edges and 50% of close edges which come from a special network, and do again, the simulation to see what's happening. So here we test that for two threshold, two timing of the starting social distancing. One is at 1%, the other one is at 0.1%. We see that if we start that very soon at 0.1%, the plateau is pronounced more. But when we start at later, for example, at 1%, we have a rise and to reach the peak of epidemic and stay that for a short time and start declining. We see a peak and decay, dynamic in the epidemic. So here, as a conclusion, we wanted to understand, first of all, the power law behavior and also plateau behavior of the coronavirus data. We use network model to see how it is, to understand why it is happening, and we realize that it is because of the, first of all, the network structure, second of all, starting social distancing in the middle of the epidemic, depending on the time of starting that. So this result is informative because, as a case study, I can tell you, for example, at the time that we had lots of new cases in New York, but not that many cases in California, both the states start social distancing at the same time. When we observed that in New York, we didn't have that prolonged plateau behavior, but in California we had. And the reason based on our model was that, starting of social distancing in California very soon. That's why, it starts showing the plateau behavior. However, our model is subject to some limitation. First of all, we have some uncertainty about the structure of the network. The network that we use are some toy networks that most of the time, our real world network is not like them, is more complicated than a scale-free or, a special network and so on. So we have to capture that. The second of all, the reason of the plateau may be because of the uncertainty about the data. If we assume, although unlikely, if we assume that, we don't have enough tests, per day to capture more infected people. So to capture the first limitation, we are going to use our model for a real world network, which is the network of people in New Orleans. It is a synthetic network, which is statically in agreement with social network of people in New Orleans, which is defined based on, different activities. The edges of the network are defined based on different type of activities like household activity, work activity, school, and so on. And the edges are weighted based on the time that people spend with each other. So we are going to use our model on this real world network to see if we see, the same behavior on that or not. So this is the end of my talk, and thank you so much. In case you have questions, I'll be happy to answer.
Excellent. Thanks so much, Asma. Very interesting work.
Okay.
Looks like we have one question in the Q&A from Jacob. Did you collect information about regulations passed per state per date? And do you have this for all states?
It is not for all states. It is just for 15 states. We collected that data around May, and it is just about 15 states. We collected the data from this state because, we wanted to categorize them based on their behavior, based on their patterns. So we also look at the data from other countries as well, which, we didn't mention that here, but in some other countries also we saw similar behavior of the plateauing, in the data. But we didn't mention, we just focus on US states here.
Okay, great, thank you. I don't see any other questions currently, so we may have more time at the very end to come back if there's more questions. So then I'd like to now move on to Dr. Pilar Fernandez. Pilar?
Hello. Yes. I'll share my screen. Thank you. Let me just work through this. Okay. Just give me a minute. I just want to put it in presenter mode. Sorry.
It's okay.
Sorry, I'm going to share it again.
No worries.
Sorry for the technical difficulties, of course. Okay, here we go again. Okay, so you still see you don't see my notes, right?
No, we just see your slide.
Okay, perfect. I just wanted to make sure. So I'm going to be talking about an agent-based model that we developed for COVID-19, especially focusing on South America that has a very particular epidemic trajectory. And I'm going to focus particularly in Buenos Aires metropolitan area, just because the team we have is from Argentina, and that's where we have data from. I'm originally from Argentina, so when COVID-19 started, I was contacted by two professors from the University of Universidad Nacional de General Sarmiento in Argentina, that they started a modeling network for COVID-19 in an effort to help with policy-making decisions and trying to understand a little bit better what was happening in the country as with the epidemic. So we started this network in early April, and we have gone a long way since then, not just us, but the epidemic as well. So just to quickly introduce the team, the people that started the network are Fernando Momo and Leonardo Sarabia. And the other person that is involved in the particular agent-based model efforts is Lucia Rodriguez Planes. She's from the National University of Tierra del Fuego, which is in the southern tip of Argentina. And we have other collaborators in the network that have contributed to this model in particular. Andres Rigur, Juan Aparicio, and Adriana Schiavini. This is just a picture of one of our latest modeling meetings over Zoom. So as I mentioned, Latin America had a very interesting trajectory in terms of COVID-19, with, for example, Peru having a very rapid, Peru and Brazil that didn't have, well, particularly Brazil didn't have really strong restrictions at the beginning, so the epidemic took off really quickly. Peru had restrictions, but from the data we have now, we know that it started, the first few cases started earlier than they started the restrictions. And then we have countries like Colombia and Argentina, which, in spite of having really strong restrictions in April and through May that really restricted the number of cases, they were never successful in stopping transmission altogether, like in other countries, like in Australia or New Zealand. And in the end, it really, what happened as part of, we think, could be quarantine fatigue and the necessity of also working, and the economic consequences of the quarantine were pretty important in this country. So as a combination of all those things, the epidemic took off, and especially during the winter months, which in the Southern Hemisphere span from July to September, you can see an increase, particularly in these two countries. But yeah, if we see it in like a worldwide perspective, the epidemic in Latin America, it really, we saw really high mortality rates, and it represented 1 in 3 of the deaths that we saw worldwide happen here. So we really need to understand a little bit more about the dynamics of the epidemic in Latin America in particular. And one of the hallmarks that COVID-19 had in Latin America is high attack rates, which could be an explanation of certain variables that I'm going to talk a little bit farther than this talk. But for example, in Manaus, in Brazil, almost 3/4, and this is a recent report, had been affected by COVID-19, had been infected with COVID-19. In other cities, like in Sao Paulo, it was about 30%, and in some parts of cities in Buenos Aires, and I think there are other reports in Colombia as well, they were high as 50%, but there was a high heterogeneity between regions. And what factors could be playing a role in this high attack rates? Well, as I mentioned, there's a lot of informal economies. So the COVID-19 restrictions and quarantine have a devastating effect on this. So people are not able to quarantine and stay at home as intended by governments. There's also high socioeconomic inequalities, and we have talked about the socioeconomic inequalities playing a role in several countries, including the United States, but in Latin America in particular, it is kind of a hallmark of our societies. So I think it would be playing even a higher role, and especially determining geographic heterogeneities even within cities. There's also a high proportion of the population living in urban areas. So unlike other developing regions, there's one of the South America has one of the highest rates of urban population. And there's also, like in these areas, there's high overcrowding. There's a combination of stage 3, stage 4 demographic transition, according to the demographic model. So there's high, but also again, there's high heterogeneities, not even between different cities in the country, but also between within the same city in different regions in the city. So for example, slums could have different demographic characteristics than other ones. And there's also one thing that plays a big role in all this is the cultural and social norms. So as part of this network, we developed an agent-based model of COVID-19, where basically each individual or agent has contact with other individuals inside a bipartite network, where we have houses and work spaces. And in the tradition, we use the tradition of the agent-based models proposed by Ferguson et al., first for avian influenza and then for COVID-19. Kind of using this network of houses and works and people traveling from one to the other and spending different amount of times in each. And the Asian states swooped, where basically we use a compartmental model in a tradition of a CSER model. And we use basically, we tweak a little bit the model proposed by Mordecai that she gave a talk earlier this year about this. So basically we have the susceptible individuals going into exposed and then transitioning into an infectious state where they have some period of time where they start developing symptoms if they do, and it's called IH. And the IH, the asymptomatic individuals can then transition into hospitalized, which is the big H, which are basically going to the hospitals and they can die or they can recover. And then you have the individuals that are asymptomatic, but they don't have severe disease. So they go back and quarantine in their homes and they isolate in their home, and they recover mostly. We also included one transition from infectious people that didn't go to the hospital but died and they were identified postmortem. On the other hand, we have the asymptomatics that they are infectious, but they never develop symptoms. So they can be infectious for the whole period of time, while these symptomatic individuals don't, once they are identified with symptoms, they don't contribute to onward infection. So this is a snapshot of the model we develop in NetLogo, and we're for parameter estimation, we did an interface with R. And the agent's activities are basically the travel time between time at work and time at home, which is a possibility for community transmission. Within the travel time, we also include trips to the grocery store and time spent outdoors. So for parameterization, we use, for non-context specific parameters, we use the literature, and that's the MIDAS COVID page was really useful to extract some of that. So for example, some of these parameters are the time of individuals in each state, the proportions of asymptomatic, and the proportions of hospitalized patients. For context-specific parameters, we use the data from the Buenos Aires metropolitan area. And basically, we estimated the transmission parameter, VIDA, and the hours spent traveling from and to work. And if you want to see updated results, we created a website that it's in Spanish and soon to be translated, but this is where we're posting all our latest results. So just to go a little bit into some of the exploring of the data we have had and our preliminary results, we basically did a different combination of scenarios. So some of the graphs are in Spanish, so I apologize for that, but I'm going to translate really quickly. This is the number of deaths predicted by the model between different scenarios. And the scenarios were a different combination of a reduction in work and reduction in travel time. So using the actual data, which is this red line here, we identified that scenario 8 and scenario 3 were the ones that adjusted the best. But also there was a lot of, it started departing towards August and September. It started departing from these scenarios. So, and these vertical lines are the different phases in the epidemics and the different restrictions that were imposed in Argentina. So we need to dive a little bit into what was happening in this time period. And for that, we also model as an outcome of the model, we can analyze the the intensive care units beds, so the capacity that we had in Buenos Aires as a result of the model, and how long or when the different scenarios would predict that. As I mentioned, scenario 3 and scenario 8 were the ones that predicted best the dynamics of the system, especially at the beginning. But the system actually in Buenos Aires never got saturated. So this is interesting to analyze specifically what was happening in this time period when it started departing. And actually, there was less death than expected by the model. And this is the cases. We didn't use cases to estimate these parameters because the definition of case changed over the time period. So who was getting tested changed a lot over time. And so there were not really good estimates. And just to expand it a little bit, we started looking into a little bit beyond the city of Buenos Aires and expanded to neighboring areas. So this is Buenos Aires province as a whole, which would be the province where Buenos Aires is adjacent to. And we start seeing that there's a scenario 2 started contributing more, and it was characterized by less reduction in work, and there's actually not reduction in traveling. So this is interesting because we can think about socioeconomic inequalities here. And just to give you a view, we didn't fix the beta. So the beta parameter was estimated from the different scenarios. It was a free parameter, but we can see that there was a difference between traveling time, the difference scenarios that we model. And also here, the other thing we compare is cities with different population size. So for this proposal, this is work that we've been working through since the beginning of the epidemic. And for this proposal in particular, we wanted to see basically what was the relative and combined effects of population age, household composition, and overcrowding in the spread of COVID-19 in South America. We know that there are demographic difference between how high and low medium income countries that could translate into different dynamics of COVID-19. But there could be also trade-offs between different demographic characteristics. For example, the age structure and overcrowding, which haven't really been thoroughly explored. And so we hope to give a few insights with this model once we incorporate those demographic characteristics in the model. And then we also one of the advantages of having this agent-based model set up is that we can explore different adaptive behaviors. So for example, changes in mobilities at a household level. And for example, if there's one case in the household, does everybody isolate? So is the person that actually is the case isolates and the household members also quarantine or not, and the effect of that. And also if we can explore some mitigation efforts at the workplace and what that would look like. And now, given we have the vaccine coming in, we can even use that and how would people react and behave towards vaccine if it's available, who's going to get it, and what the effects will be on the transmission. Also, one of the other things, as I mentioned before, this geographic heterogeneity in Latin America, that it's also associated with demographic and socioeconomic inequalities. And so in Buenos Aires, there's the presence of informal settlements, where the mitigation strategies for COVID-19 might be difficult to implement because it might represent a unique challenge, creating asynchronous epidemics that might determine the persistence of the virus in a metro population, for example. So to explore these effects of geographic heterogeneity, we have partnered with Facebook program Data for Good to access spatially explicit mobility data from Buenos Aires metro area. And this data will be integrated into an agent-based model to derive travel and mobility patterns, and also the connectivity matrix across neighborhoods and across municipalities within the metro areas as well. So this is kind of an example of the data we have been working on. And just to finish, we have a little bit of other impacts. So we're partnering, one of the intentions of this network was to partner with decision-making, to participate in the decision-making process. And we were hoping that this modeling efforts can help in the 3 different aspects of the management by allowing a better estimation of risk of saturation in the hospital system, the mortality and the costs. It would also allow for comparative evaluation in the efficiency of different measures of mobility restrictions and prevention. And it makes possible to identify critical points of insufficiently known parameters or mechanisms that we need to explore. So with this, thank you. If you have any more questions or are interested, here's my email. And as I mentioned, this is the website for the model. Thank you.
Excellent. Thank you, Pilar. Really interesting to see the in-depth work that you're doing in that region. Anybody have any questions at this point? Okay, we have one that's come up in the Q&A from Xiang Ren. Did you consider the heterogeneity of individuals, for example, different traveling time, different fatality rates, etc., for particular individuals and groups?
No, in that preliminary model that I show, but that's the intention, particularly by adding age structure of the group and using different contact rates between different age groups, and also, well, different traveling times for age groups, but also different mortality rates and different proportions of asymptomatic and symptomatic patients.
Okay, thanks. I don't see any other questions right now, so I'll go ahead and move on to, thanks again, Pilar. We'll go ahead and move on to Tom.
Hey everybody, let me just my presentation up. Hopefully everybody can see the slides.
Yes.
Okay, you can, okay, great. My name is Tom McAndrew. I'm an assistant professor at Lehigh University, PI, the Computational Uncertainty Lab, and I'm here to talk to you today briefly about aggregating statistical models and human judgment. The grant and the project is broken up into 2 main goals. The first goal is to provide probabilistic forecasts of the US COVID-19 outbreak by combining predictions from computational models and from expert forecasts. Now, why might we want to do that? The idea is that forecasts provide public health officials actionable information they can use to make informed decisions. Some of those decisions might be promoting public health campaigns. An example here is for the flu, fight the flu. Another one that's probably a little bit more pertinent to COVID-19 is about vaccine availability and also general kind of infectious disease burdens, such as hospital burdens. These are the types of, just a subset of actions that public health officials might take, and forecasts might alter their behavior to take them in a different way. I wanted to break down this project first. The first part is to provide probabilistic forecasts from computational models. Shown here on the left are a subset of computational models from the COVID-19 Forecast Hub. And there's some pros and cons to computational models that I think are important to talk about. Pros by far are that it's scalable. You can see here in this picture, you have forecasts from 6 computational models. On the horizontal is time, on the vertical is incident deaths for the US national level. And these forecasts are not just for the US national, they've made forecasts for all the different states, and it's fairly fast to do that. Most computational models have transparent assumptions. You can find these assumptions, and they should be very easily listed. Computational models are also, for the most part, reproducible, right? They are deterministic algorithms that produce probabilistic predictions about some target. And if you run the code again, it should produce those same predictions again. That said, there are also some cons. There's pros and cons to every approach. One con is that computational models can only access formatted, structured data. computational models can't talk to your friends or to their friends or to other friendly computational models, right? They input training data, output predictions. They also cannot necessarily change the form of the model form, right? You usually code the form of the model, and what changes is the input data. So it can be difficult for computational models to kind of morph their assumptions or the form of the model. The other part of this is providing probabilistic forecasts from expert forecasters. There's pros to collecting forecasts from experts, from humans. One of them is that it's fast. There's no downtime in sort of building a computational model. You just have to build a form and ask the questions. They're flexible. Switching the target, whether or not it's incident deaths, incident cases, hospitalizations, is a matter of changing the question posed to the expert. Something I think that's a particularly strong pro is that you can get commentary and rationale from an expert about the forecast they made, why they made that forecast. If you ask a computational model, I know that the quarantine's been long. Hopefully the computational model will not talk back to you, but experts can. Another pro is that humans in general, and really experts, have access to unstructured or subjective data and previous experience. There's also cons. Every time you ask a question, it takes human time. And so we can't really scale human forecasts the same way that we can computational models. I can't ask someone to give me a forecast for every state in the US. That's unreasonable to ask. The assumptions may be less transparent, their predictions. They're not laid out in an algorithm like a computational model would be. So it could be a little bit less transparent. Often less reproducible. Whether or not people agree with themselves at future time points has been it's not 100% correlated. If you ask somebody 2 hours later, 2 days later, they may give you a different forecast for the same target. And something that I think everybody's aware of or should be aware of are that cognitive biases may impact forecasts. We have just a slew of cognitive biases, and those need to be accounted for. The idea of this aim is that is to combine computational models, which have access to this structured data. This is on the left-hand picture in the information column. Computational models have access to this structured data that they can build forecasts from, and experts also have access to this structured data, but in addition, unstructured, subjective data. The goal is that the hope is that by combining them, we can build a more accurate, what I call a meta forecast, an ensemble of computational models and of experts. To prove to you that I'm not just blowing smoke, I know a little bit about this area. We've done this before. We have asked experts to forecast, for example, the predicted number of deaths by the end of 2020. And here are their forecasts on the top left. On the horizontal is the date the survey was issued to the experts. You can see it's quite early. On the vertical is the predicted number of deaths. The black dot is the median. The blue bars are the 5th and 95th percentile, except for the last survey, which was the 10th and 90th percentile. In the bottom left, we don't have to ask just objectively scored questions like deaths. We can ask things like, how many total US SARS-CoV-2 infections are there in the US currently? Something you can't really ever know. We can still ask that question. You can see here in the bottom left, there was 7 surveys that we asked this question of experts. They provided forecasts in green here. The green dot is the median, and the green bars are the 10th and 90th percentile. These were experts in the modeling of infectious disease. In the right-hand column here are experts in vaccines. And so you can ask questions, and we did ask questions about the efficacy, timing, and availability of a SARS-CoV-2 vaccine in the US. So we've done this before. We know a little bit about eliciting expert forecasts and have learned a ton from making mistakes and doing things right and doing things wrong. The plan is to ask some questions in January 1. These draft questions are as follows. What will be the number of adult and pediatric previous day admissions to the hospital? What will be the number of new incident deaths due to COVID-19? Number of new confirmed positive cases? These are kind of traditional sort of questions that you might ask a computation model that we can combine. Expert-only questions. By what factor should the forecast hub's ensemble model be multiplied by? So is it an underestimate or overestimate? What do you think? Number of cumulatives. We can also ask these kind of counterfactual questions, which are the cumulative number of deaths if more than 50% of people get vaccinated by February, or if less than 50% of people get vaccinated by February. What do you think the cumulative number of deaths will be? There's a lot that goes into a question. On the right-hand panel here is kind of the anatomy of a question. First, it's the ask. For example, what will be the number of new confirmed positive cases? We give experts a brief summary background. So the number of new positive cases can indicate the degree which the virus is transmitted, blah, 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 et cetera, et cetera. We usually provide a plot of some sort to show them a trajectory. In addition, we'll give a ton of data sources and links to sort of helpful things. And we also importantly give the resolution criteria, how we will determine the truth of that question. So this is what goes into every single question that we'll ask of experts. That's the first aim. The second one is to guide public health officials on potential interventions by collecting probabilistic predictions from experts in the modeling of infectious disease through a Delphi process. Here's what happens. We provide these forecasts. And a lot of times I hear, these are great. What do I do with them? What action should I take? And my answer is, I don't know. I'm not trained to take action. I'm trained to build forecasts. So I thought about this, why don't we ask experts to predict sort of optimal interventions to take? That's the goal. Here's the process. We're going to ask experts to identify the top 5 most effective interventions that they feel would be effective to take. Each expert will rank the impact of those interventions. So I think this is the most impactful, the second most impactful, the third most impactful, etc. They're going to be required to give a rationale for each intervention, why they think it's impactful. The next step is we're going to take, so every expert is independently doing this. The next step is to take all those interventions and all those rationales and collate them together and send back that summary report to every single expert. Say, here's this summary report, here's what everybody else thinks, here's why they think it, and allow them to revise their top 5 ranked interventions. At the end of the day, for both the first project and this second project, which is advising people about optimal interventions to take, we're going to build a summary report for each of those projects and one combined. Summary report has a few different pieces, usually an introduction of predictions in context, a line list summary of the predictions that were made, a detailed report of probabilistic predictions, and a really detailed, almost overly detailed list of every single question that was asked, how it would be resolved, any mathematics that's involved, and combining them, etc. Finally, I think absolutely everybody in the MIDAS community, I would consider an expert. And so I'd like to invite you, if you would like to join, either project 1 and project 2, or both projects 1 and 2. So if you would like to make these predictions about the evolution of COVID-19, or about predictions of effective interventions that we can take, please join. The link to participate is here. I'm going to put it in the chat for you, so it's easy just to click. So I just put the link in the chat that you can click, and please fill out that information to participate. I would love to have you in this project. And last but not least, maybe the most important slide for me at least, thank you to the MIDAS Coordination Center. Thank you to experts who have already agreed to participate. Thank you to the infectious disease scientific community. It's such a great community to be a part of, and really a tertiary goal of all of this work is to bring us closer together as a scientific community. And thank you to my 2 industry collaborators that will be helping me with this project, Metaculus and Good Judgment Inc. And I'd like to introduce the newest unofficial MIDAS member, which is my 2-month-old daughter, Maeve McAndrew. And she's very experienced. I'm sure that she'll be accepted as a MIDAS member at some point. She's given several lectures in statistics already and is much more popular at office hours than I am. And thank you.
Very nice. Thanks so much, Tom. And what a great way to end the final MIDAS webinar of 2020 with a Christmas picture of your daughter. So thank you. That's very nice.
Sure.
And I hope she becomes an official MIDAS member in the future.
She's filling out her application.
Right, yes. So we have a few minutes left for questions. If anybody has any questions I'd like to ask Tom or any of the other panelists. see, Jacob. Jacob, would you like to ask a question? I'll let you speak if you'd like to ask a question.
Yeah, it's very interesting because I was doing something very similar for diabetes this year, also incorporating expert information. Have you done some other research on top of it? Like in other diseases or in other directions other than COVID?
Yeah, good question, Jacob. And sorry, I think I also owe you an email. Yeah, I haven't done anything else yet except COVID-19. I had done a previous study when I was working in industry with interventional cardiologists and their predictions of clinical trial results, but that was never published.
Okay, we should talk offline. I'll send you an email. It's very
I agree,
interesting what you're doing. Some good ideas.
Thank you. I think so too.
Okay, I don't see any other questions, but oh wait, we have one more from Stuart. Have you posted your expert opinion consensus results on COVID vaccine characteristics as preprint or a publication?
I'm writing the preprint right now. There is a dedicated GitHub. I'm happy to put a link there to see the summary reports, the code, and actually the consensus predictions that they've made. I'm happy to get that right now and put it in the chat. But look out for a preprint. Finals just ended, so it's writing time. So give me about a couple weeks, and there will be one.
All right, thanks, Tom. And thanks again so much to Pilar and Asma for the excellent presentations. Really appreciate your time and congratulations on your awards. And thanks to everyone for joining us today. Hope everyone has a safe holiday season, and we look forward to seeing everyone again in January. Thanks, everybody.
Hey, bye now.
Thank you. Bye.